is similar like the one I gave recently on IMCAS in Paris, but I also included slides on Microfat and SVF here because I learned that you're very interested in this procedure as well. So it will be approximately 20 minutes lecture, and then we have more than enough time to answer all the questions. I already have a long list of questions received this, and I'm well prepared to answer everything. And if new questions come up, of course, I will answer them as well. So let's get this presentation started. Here is my disclosure. Beside working in my private clinical practice, I'm working for Arthrex, was doing this for the last 9 years all around the world, giving lots of trainings, lectures, and also expanding the product portfolio from Arthrex. And of course, I use all these products as well. My concept in my practice is to work with the best companies and to use the best brands. And for PRP, PRF, Microfat, SVF, I believe these are very good products. So having a look on this slide, you see properties of PRP and PRF. First thing, terminology. PRF, this term was used in dentistry for around 25 years now. But meanwhile, new preparations are available, and we can speak about fluid PRF. And this fluid PRF is the second generation of PRP, as some authors call it, because this fluid PRF has several advantages. The fluid PRF has no anticoagulant, and this allows it to form a clot and release the growth factors over many, many days, over weeks in fact. And you have a desired microclot, and this is, I will show you some slides, more effective than the conventional PRP, where you have an anticoagulant in. This anticoagulant always binds calcium, and then it's impossible that out of the fibrinogen, which is always in the PRP or also in the PRF, of course, it cannot form the fibrin clot because the blood was anticoagulated before. But if you have no anticoagulant in, the conversion from the fibrinogen to fibrin and the fibrin clot is possible, and this releases the growth factors in a sustained way, which is very beneficial. Activation, well, for the fluid PRF, we do not need external substances when we inject it into the skin because collagen fibers activate it endogenously. Whereas for anticoagulated PRP, you should consider activation with calcium chloride, calcium gluconate, or thrombin, because there the anticoagulant was binding the free calcium in the blood before. But for fluid PRF, no activation required for our indications. And there are some advantages, namely that you have a sustained mode of action. Here you can see a study on platelet concentration. So besides having no anticoagulant, it's also important to have enough platelets. But what are enough platelets? According to literature, a good concentration for skin rejuvenation is 2.5 times over baseline. For treatment of hair loss, the ideal concentration may be even higher, different tissue, because you want to have especially more new blood vessels, neoangiogenesis, and there a higher concentration seems to be beneficial, but 2.5 times is also good. And this is substantially higher than what you can get with tubes. With tubes, just on mathematic assumptions, when you collect 9 ml and you're getting out 5 ml of blood, yeah, let me use my calculator, 9 divided by 5 means, or 9 divided by 6, let's say 6 ml, you get a concentration 1.5 times over baseline. Whereas when you harvest 15 ml more, Arthrex syringe allows you to harvest 15 ml and you get 5 ml out, then you get a concentration 3 times over baseline. So the more blood you have at the beginning, the more PRP you can get, anticipating there is an efficacy between 80 and 90% when you use a good system. When you use one of the tube-based systems, which contains a separation gel, this separation gel can absorb a lot of platelets. So using a system like the double syringe without the separation gel has benefits because you do not lose the platelets. There are studies showing that the platelets get attached to the separation gel and you lose them. So having no gel is a big benefit. Beside platelet concentration, it's important to have a fluid PRF or PRP, which has a low concentration of white blood cells. Maybe the term white blood cells is too generic. We should say that is poor in neutrophils because the neutrophils have detrimental effects as they activate unspecific proteases and toxic substances. And of course, they cause inflammation. A low concentration of red blood cells is desirable because at their degradation, they release reactive oxygen species that can induce inflammation and cell death. This is the paper that I want to show to you regarding the difference of PRP and PRF. So PRP with an anticoagulant is good. You see here skin migrated 200% more in PRP versus control. But fluid PRF is much more powerful. It's even better. You see that the skin fibroblasts migrated 350% more. So that's 1.5 times the efficacy of PRP. And here on this graphic, you can see it. You can see the migration assay, PRP better than control, obviously, but fluid PRF significantly better than PRP. So go for the best tool that you have, and this is certainly fluid PRF. Regarding the preparation, I want to show you this video. So I'm taking 15 ml of blood into the Arthrex ACP double syringe. I put on the red stopper and put it into the centrifuge. There are numerous centrifuges on the market, but all of them have a special rotor. They have a swing out rotor. So it is spun in a horizontal position. And this is important because the separation of the tissue is much, much better in a horizontal position. You can reduce the G-force, then you do not require an anticoagulant. If you have the right plastic, your platelets do not get damaged when the G-force is low and when the plastic composition is right of the material, and then you get your fluid PRF. And here you can see you're getting 5 to 6 mLs depending on the hematocrit of the patient. And one more characteristic is remarkable, namely that in this fluid PRF, the very light particles, the platelets, are distributed homogeneously. They are everywhere in the first milliliter, the second, the third, the fourth, the fifth. I have done research on that. This was using a cell counter, which counts the platelets. And we found out that in the first, second, third, fourth, fifth milliliter, it is very rich in the platelets. So there is no buffy coat like with the tubes. With the tubes, you have a hard spin and you spin down all the platelets due to the very high G-force. And this mixes with leukocytes then. And then you have this buffy coat. The problem is, as I said, either you mix it with the leukocytes, that's the conventional preparation, which is not very favorable for aesthetics because they have negative effects, or you have a separation gel, which separates it from the leukocytes, but is also not favorable because independent studies showed that lots of platelets get stick to that separation gel and you never ever get them out again. So from my perspective, the best preparation is the fluid PRF to reduce the G-force, to have a syringe like this ACP double syringe with the right material characteristics, to spin it at the low G-force, 350 G for 5 minutes and in a horizontal position. And then you get out your PRP, which is everywhere rich in platelets, approximately 2.5, 3 times over baseline. And you get the leukocytes at the border to the red blood cells. And you can decide if you want to take out these leukocytes the very last half cc, or you want to leave them in. As you can see here, I decided to leave them in the syringe because for skin rejuvenation, I do not want to have the leukocytes. Whereas for treatment of chronic wounds, leukocytes can make sense, especially at the beginning. When you start the treatment, you need them for a natural debridement. Okay, on the next slide, you can see how reliable this ACP syringe is to prepare fluid PRF. You see that the average platelet concentration in 20 subjects was 2.42 times. Another study, I think 2.6 times. So this is absolutely in line with the values that the company gives you in the marketing material. Whereas some other PRP manufacturers, they have very, let's say, interesting, good numbers in their marketing material. But when you look on independent studies, this is an independent study from a hospital in Germany, then with some other manufacturers, well, you do not even get the same amount of platelets that you have in your whole blood. Yeah. So in fact, they tell you you purchase a PRP kit, and in the end, it's a PPP kit. So when you want to do PRP or fluid PRF treatments, also use the right technique and good materials. This is my clear advice. Fibrinogen, I mentioned this before. Yes, this ACP fluid PRF is obviously rich in fibrinogen. And here is a study showing that the fibroblast proliferation takes place over many, many days. So the study stopped here after 10 days, but you can see on the graphic that also after 11, 12, 13, 14 days, there will be still fibroblast proliferation visible. Yeah, just the study stopped here. And this is the advantage of the fluid PRF, what I mentioned before. When you have this fluid PRF after injection, out of the fibrinogen, there's fibrin, and then the desired microclot, the fibrin clot, which releases the growth factors in a sustained way. Skin rejuvenation, let's talk about indications. Of course, the so-called vampire facelift became very popular. And let me explain you the mechanism of PRP and fluid PRF. So you remove photodamaged extracellular matrix, increase the proliferation of dermal fibroblasts, synthesis of new collagen fibers is a mechanism, and of course, acceleration of wound healing. And I reviewed literature and want to present you that now as well. So when you have a look on PubMed, for skin rejuvenation, you find this systematic review, 24 studies included, 8 RCTs representing 480 patients in total. And based on the results, they say that the facial skin appearance, texture, and lines improved. Periorbital fine lines and pigmentation may also benefit. I will show you some pictures from my own clinical study later. And that adjuvant PRP accelerated healing after fractional laser resurfacing. And this is really important. They say, although the degree of improvement was typically less than 50%, patients generally report high satisfaction. For me, patient satisfaction is a very important marker for success, and the patient satisfaction is high with these treatments. And less than 50%, it's a natural treatment. And of course, we cannot do miracles, but we can improve the pigmentation. We can reduce age spots. And when you have a look on the pictures, you will clearly see the benefits. And 40–50% improvement is a lot, in fact, when it comes to a whole facial procedure, or when it comes to the lower eyelid area. Of course, we can't do miracles, but we can do a good treatment to our patients. So this study is also available open access. If you go to PubMed, you can read it. You find a link there. And I was one of the authors of this paper. And I'm happy to show you the before and after pictures now. And you see the patient here before, after the first, and 4 weeks after the second injection of this ACP fluid PRF, and you see the gradual improvement. And it's important to know, it takes time. We build new collagen fibers. This is taking time. So I tell the patient we need 2 to 3 procedures, and they should be spaced approximately 1 month or 6 weeks apart. This is a patient also, you see the before and after pictures and the gradual improvement, how it improved. This lady is obviously older, and also in her case, you see an improvement. And some of you may say, well, this improvement is a mild or moderate improvement, but in this area, it's very hard to get results with minimally invasive treatments. HA can be quite risky using it, and if there is no substantial loss of volume, then there is no indication for HA, and frequently the problem is just thin skin. We'll show you the next patient where you see that she suffers from discoloration and puffiness. So in this case, for example, HA will not help you. Also, Botox will not help you. Of course, I'm using Botox sometimes for crow's feet, but in the medial part, it won't help you at all. And this is where the fluid PRF is a good alternative treatment modality, the lower eyelid area. And here you can see the patient before and 4 weeks after 3 injections. Another patient where you see a benefit, but of course you also see limitations. This would be a good candidate for a surgical treatment for blepharoplasty as well, but the patient didn't want to undergo surgery and was happy with the result. He knew in advance we are only able to get a moderate improvement. I told him this honestly in advance, and Dr. Aus told him this as well, and still he was happy. And here you can see that in the clinical study, we quantified the success. So we used the cutimeter to measure the elasticity of the skin, and we found out that the elasticity and firmness became better. A lower R0 value means a firmer skin. So this value dropped steadily, which is very positive. And also these values were dropping and indicate a more elastic skin. Yeah, beside that, we found out that with having a fluid PRF, the patients do not suffer from the heavy burning sensation, because the anticoagulant usually has an acidic, unfavorable pH value. And this causes irritation to the skin and the burning sensation. If you have no anticoagulant, great, more effective, fluid PRF and less pain. And this slide is interesting because it shows you that the platelets find their way into the skin also when you use needling. And the study from Sasaki tells you that you should also reapply some minutes after you did the needling. You should reapply the PRP or fluid PRF topically again, because the bleeding stopped and then the channels are still open and the skin can soak in the platelets. You see they really find the way into the skin. Of course, we need some substance simultaneously that it glides smoothly, but also after 2, 3, 4, 5 minutes, we should reapply a little bit. And this review from Hashim and colleagues shows in split face design, studies were split face studies, that the sites where PRP had been used additionally to needling got better results than the sites where needling was used alone or with vitamins. Based on that, Professor Pasch, Dr. Kolster and I wrote this book, and I'm happy to show you before and after pictures. These patients received needling plus PRP, fluid PRF, Arthrex ACP fluid PRF, and we injected it partially and partially applied it together with needling. And I think you all agree that these are very beneficial results and very natural outcomes. So in the lower eyelid area, you see the positive effects, but also on the general tone of the skin improved. And in these patients, you also see an improvement in the mid-face. So there was 1 ml of fluid PRF injected into the nasolabial folds. And all the after pictures here that I show you are 6 months follow-up pictures after 3 treatments, monthly treatments. And you can see that if you inject around 1 or 1.5 ml into nasolabial folds, you can get some proliferative effects there too. But it takes a lot of time, and it's not so easily to predict the outcome like it is with hyaluronic acid. So still for many of my patients, HA is my first choice for nasolabial folds. I also like to place something on the cheekbone before to do a lifting and then apply a little bit into the nasolabial fold as well. But for those who want to undergo an all-natural treatment, you could do a treatment with PRP or fluid PRF as well. And yeah, I inform the patient openly that this takes a lot of time. And if the patient is not 100% happy with that alone, you could still go for HA at a later time point. And when I treat only the lower eyelid area, for example, always getting 5 to 6 mLs into one ACP double syringe, I have materials left. And then I say, okay, we do not throw this away. Let's inject it with a cannula into the nasolabial folds. 1 minute for me. I use the same cannula for the lower eyelid area, so no additional costs. And the patients are very thankful for that. And of course, I also try to do an upselling to a full facial treatment. So first I inform them, well, we can do something for the lower eyelid area. This is the reason why you came to me. This was your wish, but for, let's say, 100 euros or dollars more, you get a full facial procedure where I inject it with some small needles into the skin. And if the patient says, I'm not really interested in, I say, okay, what I could do is the remaining part, I can just inject it into the nasolabial fold. It's really just 30 seconds for me. This would be free of charge. And you see the marked improvement also for fine lines, like in this patient, and for texture and age spots. Have a look on the left and the right side. Yes, the improvement will be most likely 50% when you count the spots, but 50% is a lot. So you can really do something beneficial for your patients. Also here, have a look on the texture before and after. Have a look on the mid-face and on the lower eyelid area. The next big topic is androgenetic alopecia. PRP and fluid PRF prolong the survival of the dermal papilla cells, prolong the anagen phase of the hair cycle, increase the perifollicular vascular plexus, and moreover, they contribute to a better differentiation of stem cells or more differentiation of stem cells into hair follicle cells. Research demonstrates the potential of platelet-rich plasma therapy for hair loss. This statement was published on the website of the American Academy of Dermatology. In some European guidelines, PRP and PRF treatments are included for this indication. It says you can use it. There is no clear yes or no, but it says you can use it. Recently, new research was done. This research is not yet included in these guidelines. So in the new guidelines, hopefully there will be a more powerful statement. And hopefully also in the American guidelines, there will be statements regarding PRP in future. But it's a very conservative society, the AAD. And when they say at their website that they see a potential, and when it's in European guidelines, it says we can use it, then we should be very confident using this. And let me present you this review and meta-analysis from Evans and colleagues. Here you see the current body of evidence. 30 studies, including 687 patients, met the criteria. 29 studies reported beneficial results. 29 out of 30, that's a really good outcome. 24 reached statistical significance, and 10 RCTs were included. And having a look here on the forest plots, you can see that it favors PRP versus baseline, and it also favors PRP versus control. Should we use PRP or PRF alone or better in combination? For me, it's not to say this is against an established treatment modality. When a patient comes in, he is under minoxidil therapy or under finasteride therapy, is fine with the therapy. I keep on going. I do not stop this therapy. When the patient comes in first, my consideration is to do a treatment that is affecting the patient the least way. And the PRP treatment is bodyzone blood. There are, apart from the needle pricks, there are literally no side effects. For me, this is a first-line therapy, and if it's not powerful enough alone, then you can combine it with the other treatment modalities. And in this network analysis, you can see that the SACRA values show you that PRP may be even more effective than the established treatment modalities, but be careful. The SACRA value, a high SACRA value means it's better, but you shouldn't overrate the percentages here. This is due to the design, due to the characteristic of this study. And what we also need to know is that the quality of the study, the level of evidence for minoxidil and for finasteride is frequently higher than for the studies with PRP that are included here. But still, it shows you that PRP is a treatment modality that you should consider to use in your private practice. In this paper, you see that you can combine PRP with minoxidil and finasteride. And let me point out this study from the United States, from New York. You see 24 patients had been included. 17 out of 24 had a positive response, close to 200 hair per square centimeter after the PRP procedure and 163 before. That makes a big difference. And the non-responders, well, at least they remain stable. I tell all my patients, I do not know how well it works in you, but in general, there are three thirds. One where we see fantastic outcome, one where we are both satisfied, and one where we may need to boost the results with other treatment modalities. And you do not lose anything if you do this PRP treatment. Now, we can't do miracles. None of the treatments that we have available can guarantee you success, but it's quite likely that you belong to these patients when you look at the statistics, that you have a benefit. And if not, we prepared the area already, and then you can do a hair transplantation. So you do not lose anything. And I want to show you some before and after pictures from the clinical study and paper, which I published together with two colleagues from Canada. And you can see here that it works in both males, but also in females. And lots of my patients are women. And women have also thinning of the hair. And frequently they do not even know that they can do something. But we can really help them. Usually the protocol is 4 injections in my private practice now, or even 5 injections, depending on the wishes of the patient. And I have a special package and promotion that when they do 4, they get the 5th one for free. And of course, I adjusted the prices a little bit before that. I have the same amount of money now that I had before, but now really this motivates everybody to undergo for 5 sessions. And I think that's the sweet spot, 4 or 5 sessions when it comes to treatment of alopecia. Here you can see another patient, and you see how thin the hair was before and how it improved 4 weeks after 3 sessions here. This patient, well, usually I'd say it's time for a hair transplantation. It was a patient that Dr. Hetz treated, and you can see here that he also had positive effects and outcomes, but as I said, usually this is not the optimal candidate. Satisfaction, patient satisfaction is very important, and in our study we measured patient satisfaction and also the clinician satisfaction. And both clinicians and patients were satisfied, and there are hardly any differences between males and females. Likeliness of recommendation is high in both males and females. And yeah, with having said this, I'm moving forward in my presentation to pigmentation disorders. Melasma and vitiligo, I found this review and meta-analysis for melasma, where you can clearly see that the vast majority of studies recommend either PRP monotherapy or PRP and needling in combination, and that the subjective patient satisfaction is really high. Also lots of pictures showing better pigmentation. So this is something what we can do beside laser, for example. For vitiligo, 11 studies included in this review, and especially in combination with excimer laser, it was a very effective treatment modality. PRP, PRF-assisted lipofilling. Recently, this meta-analysis and systematic review was published, 11 studies included, and you see that the fat survival rate was between 24 and 89% in the PRP plus fat group versus 20 to 54% in the fat alone group. So huge difference. What is also important to know is that you need a lot of fluid PRF or PRP when you combine it with fat. So in the studies where it worked well, 30 to 40% of PRP or fluid PRF were added to the fat graft. So when you inject this, either you mix it. I do not really like to mix it because it separates quickly and then it's no more predictable regarding the volumization, because a lot of the product, the PRF, will be resorbed. But what is another way is you inject first the fat graft and then again transcutaneously you inject the PRP, and then you have total control over what you're doing. You see how much volume the patient needs, and at the end you add 30% of PRP to maintain this fat grafting. Yeah, here you can see the forest plots, and you see that fat graft plus PRP is certainly superior to fat graft alone. Some tips and tricks. Some doctors ask me, can I mix it with local anesthetics? Well, I apply numbing cream on the face. This is okay, yeah, and the patient tolerates the procedure and it doesn't heavily interfere with the platelets. Whereas mixing it with lidocaine, putting some lidocaine into the PRP, I do not recommend this, because there are studies showing that there is a negative interaction between platelets and lidocaine. My protocol is usually 3 monthly intradermal injections for the skin, and also 3 monthly injections as a minimum for the scalp. And as I said, now I have a promotion with 5, which for me is the sweet spot. Combination with minoxidil finasteride is possible. Of course, you can combine PRP for skin rejuvenation with laser. You can combine it with needling, or you can simply inject it. For the injection, I like to use 33 gauge 4 millimeter long needles for the skin. I'm injecting the first millimeter, so very superficially. And for the lower eyelid area, I like to use a cannula using the TSK Steriglide, 27 gauge, 38 millimeters, 50 millimeters works as well, 25 gauge works as well, whatever you have in your practice. And yeah, that's my way of application. Of course, you can also use a mesogun if you like this, but be careful, you will lose a lot of material on the skin, on the surface. Do not wipe this away. Let it find the way into the skin. The channels will be open and it will soak in a little bit afterwards. Microfat and SVF. This is another interesting treatment modality. It's the same centrifuge, just different settings. 2,500 RPMs, 4 minutes. For microfat, you can prepare microfat and SVF, also with the ACP double syringe. You see the materials that you need. So you need cannulas, you need several syringes, and you need these small diameter connectors for fractionation of the adipocytes. So let me show you this video. You start with one incision, or on this video, two incisions, and put in some tumescent solution. Then you wait 15 minutes, and then you harvest the fat directly into an ACP syringe, or you harvest it into a Vaclox syringe and transfer it, up to you. 4 minutes, 2500 RPM, you see the three layers after centrifugation. You're getting rid of the oil. You're getting rid of the tumescent solution and blood. This also is important because it spins out the lidocaine as well, which is in the tumescent solution. And now this would be microfat when you reduce the particle size. For microfat, the particle size per definition is 1,200 microns. So you need a connector, and Arthrex has a kit which has a connector with 1.2 millimeters. So carefully shifting it 1 or 2 times between the syringes, you can reduce the particle size to 1.2 millimeters. Now you have a microfat which gives volume. The adipocytes remain intact. If you want to prepare SVF, you need to rupture the adipocytes. And to do this, you need the 1.4 millimeter connector. With the 1.2 millimeter connector, which is smaller, the problem is it's sometimes very hard to do this at high speed. But it's important to have a small diameter and high speed. This is why I clearly advise to use the 1.4 millimeter connector for preparation of SVF. And then you shift it 30 times between the syringes. So you have 10 ml of dry fat shifted 30 times between the syringes. Push it back into a double syringe. Use a counterweight which equals the weight of this syringe and 10 ml. That's the yellow counterweight. And after a second centrifugation run, you're getting approximately 1.5 or 2 ml of SVF. So you have 10 ml dry fat, and you're getting approximately 1.5 ml out. And this means you have a substantially higher concentration, 10 divided by 1.5, approximately 6 times, 6.5 or 7 times higher concentration, depending how well you did the emulsification of the fat. You can mix it with PRP if you like, but be careful. In this case, use an anticoagulated PRP, because otherwise it's very likely that it clots quickly, because the combination of these cells, the collagen fibers may play a role, which are in the SVF extracellular matrix will play a role, and this triggers clotting. So in this case, if you mix it please with an anticoagulated PRP, or apply it sequentially. Then I have here some data for you to present. This paper shows you that you get a high amount of stem cells in the SVF pellet. The graphic with disposable is done with the Arthrex technique. And you see here that you get between 2 and 3 million of viable nucleated cells per milliliter of this SVF fat pellet. And you see that you're getting between 45 and close to 50% ASCs, adipose-derived stem cells. Of course, you also get some other cells, some endothelial cells, some leukocytes, but the amount of adipose-derived stem cells is really high. Professor Brandl, the past president of the German Society of Plastic Surgeons, did a study with that technique, and here are some results. So you see they analyzed periorbital folds on this wrinkle scale, and you see that the value dropped, indicating a favorable outcome. They also analyzed nasolabial folds, and you see that it remains pretty stable after 12 months. That was the follow-up time. And we know from other research that if the patient has hardly any changes in weight, this of course is important, that microfat will be present for many, many years. So it's a long-lasting treatment. And from my perspective, it makes most sense if you can treat the whole face. Because if you're doing this with a filler, 1 milliliter here, 1 milliliter there, it all costs money. If you harvest fat and have enough fat, it doesn't make a big difference if you inject and prepare 5 or 15 ml. This really makes the treatment economic then for the patient, and results are outstanding. Yeah, Dr. Solowiecka, Miroslav Pikarski, and myself, we wrote this publication on SVF, and here you can also see that using the Guy's scale in the physician ratings, all these cases showed improvements. And Dr. Stevens published this paper with some clinical cases where he used SVF for regenerative purposes. You see these burn scars, how they improved 6 months after a single injection of SVF. You see that this lesion here after a chemical burning also improved a lot after SVF. Patient with wound healing disorder had a pretty good healing due to the SVF injection after surgery. And also for alopecia, he used it and found out that 1 year later there was a pretty good result. But I'm very careful when it comes to treatment of alopecia. The anatomy here on the scalp is special, especially at the frontal part. You must be very careful not to inject this into an artery. There are few case reports where serious adverse events occurred, but it can be really severe. So there can be a stroke, there can be blindness. And from my perspective, from a risk-benefit ratio, it's not worth doing this. So especially in the temporal area, for me, this is not a treatment that I conduct there. It's better to recommend a hair transplantation or to do a series of PRP or PRF. Yeah, you can get really good results with fluid PRF as well. And this is a very safe procedure, whereas this procedure for treatment of hair loss is associated with several risks. Yeah, that's another patient of mine, and I have treated her with SVF and fluid PRF in the lower eyelid area, and with microfat for nasolabial folds. And this was the middle picture is immediately after the treatment, so she can return to work immediately. Yeah. And the picture on the right is 3 months after, and you see that we achieved a very natural, good outcome. And as I said before, when doing microfat and SVF, I like to treat several areas of the face and not just one. Then it makes the biggest benefit for the patient. Last but not least, positioning and marketing. Off the shelf, that's HA, we all use it. We all know that we can place it on the periost or deep dermal. Botox is still the #1 for all dynamic lines where muscular contraction is the reason for the folds, especially glabella and forehead. And SVF and microfat, well, you can treat the whole face with one kit, and you're getting, usually you need 2 ACP syringes, yeah, and you can get SVF as well for areas where you need only regeneration and no volume. Fluid PRF, the second generation of PRP, alopecia, skin rejuvenation, combination with laser. That's where it can be used. It can be injected everywhere in the face to improve outcomes there. Thank you very much for your attention, and I think it's time to discuss the questions. Leanne, shall we continue?
Yes, thank you so much, Doctor. I could literally sit and listen to you all day. It's absolutely amazing. You have most definitely answered a lot of my questions, but it's okay. We have gotten a lot of questions in the market over the couple months, and I think it'll be just nice for doctors and clinics to hear it from a different perspective, especially because you work so closely with Arthrex and the design of our ACP. So we'll jump right in, get started, and then I promise I do see some messages in the chat box, so I'll do that right at the end as well. But if you have any questions after my questions, then please feel free to also put it in there. So we're going to start with the first one. What does it mean when we say that Arthrex PRF is first generation and second generation PRP?
So some authors say that PRP, the anticoagulated product, this was the old way of preparation, was the second generation. And the improvement of reducing the G-force, of having a superior centrifugation in a horizontal position, is then the second generation. So it's an evaluation from the PRP to fluid PRF. And this is also how I explain it to my patients. And some of my patients, especially the new patients, they ask me, but doctor, do you use PRF or PRP? Because on Google, they find PRF seems to be newer and better. And then I explain them, I'm using fluid PRF. This is the second generation of PRP.
100%. So the one thing that we also in the market is everyone is so excited that Arthrex PRF is out. But it's been out the whole time. We've always had Arthrex PRF. It's always been with us. So again, like I said, first generation PRF, second generation PRP. But I think because so many people are used to, how do I say, the device always being known as PRP, there's a little bit of confusion in the market, why PRP and why PRF. So that's the perfect answer for that. Second one, where does the buffy coat and the platelet poor plasma go in the Arthrex syringe?
Yeah, I already explained it. Platelets are very low particles. And if you have a very low G-force, then you separate the heavy particles out, namely the red blood cells and the white blood cells, but the light platelets, they remain in the plasma. So you have no buffy coat like you have in the tubes with the high G-force. You have PRP everywhere. All your 5 mLs or 6 mLs of this final output are rich in platelets.
Amazing. Then number 3, there are many devices on the market. Why would you choose Arthrex as a doctor?
Yeah, from my perspective, it's very important to have a product that works in a very reliable way. It's quick, easy, and reliable. I want to have a product that gives me always a top quality and not just sometimes. If you use a buffy coat system, sometimes you can catch the buffy coat, sometimes not. That's also when you look at the independent studies, there's a huge variety of platelet concentration, even in the same patient. I mean, I was appointed to prepare the PRP at Dr. Magalon's session at INCAS in Paris at the conference. And I'm doing this the 6th, 7th time now. And always the results are very consistent. Yeah, it's always his blood, and depending how well he is hydrated, there are minimal changes. But it's more or less always around 3 times over baseline. Whereas some other devices, you can see 1 year great concentration, 1 year bad concentration, and we have patient-dependent factors in regenerative medicine where we cannot 100% predict how well the treatment is working. But if we can use a system that guarantees us reliability, we just have these factors and not another confounder.
Okay, fabulous. Thank you. Question number 4. PRF is the new buzz treatment, especially in South Africa. What does PRF mean? And do all devices produce PRF?
So PRF, per definition, requires a preparation without anticoagulant. And there are two ways to apply it, either the fluid PRF or solid PRF. You can prepare a solid PRF with the Arthrex system as well, with a double spin. It's a little bit more complicated and time consuming. But the problem is then, of course, you need larger diameters, larger cannulas for injection. I do not really see a big value at the moment for this. And what I do not like is the concept of heating it up, because some people heat it up. I saw this in Australia 6 years ago. There was a big hype around this. I was in Australia last year and asked what happened. Why is nobody doing this anymore? And they said because just at the very initial stage, for a few weeks, there was a volumization effect, and then it disappeared completely. And you're destroying proteins when you heat them up. So maybe in future, this could be exciting. There will be a new device also from Arthrex available where you have a huge amount of PPP and some highly concentrated PRP. And maybe in future, it could be interesting to heat up the PPP to give a scaffold and to mix this with the PRP. But that's an assumption from my side now. I will try this out, of course. Yeah, and I will inform you how it goes. And when the device is ready to for you in South Africa, I'm happy to share my experience on that as well.
Fabulous. Well, we're excited to see it, definitely. Number 5, why do we choose to spin at a lower speed and at a horizontal flare?
That's physics. So a horizontal separation, of course, in 45 degrees, the centrifuge is smaller. Centrifuge is cheaper. But the better separation with the centrifugation is the horizontal position, because there you have the maximum efficacy when you're using the centrifugal force, and you have this big advantage with that centrifuge. The other ones are cheaper, but that's the better way of using it. And you can lower the G-force. You do not need anticoagulants and can prepare it fluid PRF with that.
Exactly. And like you said, that's where the science comes in. Number 6, what is the difference between, I think we've said it. What is the difference between PRP and PRF? So we know that obviously PRP is where we have the anticoagulant in it, and PRF is where we don't have an anticoagulant. And then when we inject, that's where that's where we are able to coagulate in the skin and make your
exactly. And also the fluid preparation will make this desired microclots and is better for injection than the solid one. That's why I like that more at the moment. Yeah.
Perfect. Would you choose to treat certain areas with PRP over PRF? And if yes, why?
Well, when mixing it with SVF, for example, you need PRP, you need the anticoagulant, otherwise it clots. For all the other preparations, I prefer the fluid PRF due to the reasons I already mentioned. It's more effective.
No, that's perfect. How would you enhance the results of PRF in your practice?
Combination makes the perfect treatment. We have a holistic concept for the patient. Of course, PRP, PRF is just one part. The patient comes in, and when the patient wants a full facial rejuvenation, PRP is great for the surface, the texture of the skin. PRP can be a great minimally invasive tool for the lower eyelid, where I frequently have no other options. But still, for, let's say, the glabella or for forehead lines, I need Botox to reduce the activity in the muscle. And for three-dimensional rearrangement, either body's own fat or hyaluronic acid is the first line therapy, obviously. But there is enough what you can do with PRP and hair loss, as I said. Combination with minoxidil is also a good idea.
Perfect. How often do you recommend doing PRF treatments? I know this was said in your presentation.
Well, for the hair, as I said before, I think 5 times is great. 3 is the absolute minimum. Better do 4 or 5. And for the skin, at least 2, better 3.
Perfect. And we would do it around 4 weeks apart, correct?
Yes, that's approximately 4 weeks. Can be 3, 4, 5, 6 weeks.
Okay, perfect. What does Arthrex mean when they say 20% more output than tubes?
Yeah, usually with the tubes, you get approximately 4 milliliters of PRP. Some tubes give you 5 milliliters of PRP, but to be honest, in this 4 or 5 milliliters, there is always 1 milliliter anticoagulant in. So with the Arthrex, you get 5 to 6 ml of PRP, and comparing this with the tubes, it means you're getting 20-25% more final product, more output.
Perfect. That is one of the things we get asked a lot, so that's great. What does Arthrex mean when we say, this is also a very big question that we get a lot of. What does Arthrex mean when we say 2.5-fold yield versus baseline?
So in your whole blood, this is the baseline, you have between 175 and 450,000 platelets per microliter. This is a normal range. In most patients, it will be around 200,000. That's the most frequent platelet concentration. It always depends on the hydration of the patient, but let's work with the number to keep it simple, 200,000. Yeah. If you prepare this Arthrex ACP fluid PRF, you get an increase in this concentration by factor 2.5. So 200,000 multiplied by 2.5 means 500,000. If the normal value of the patient, the starting value is 300,000, you get 750,000 out. This means it's always multiplied 2.5 times. 2.5 plus minus 10, 15, 20%. That's the accuracy. That's the range. So you get in a reliable way a concentration between 2 and 3-fold over baseline. Mostly it's around 2.5 times when you look into the independent data. Yeah. I like this statement much more than working with absolute numbers, because some years ago, there was a very interesting definition of PRP. They said PRP is 1 million platelets per microliter. And this definition, to be honest, was based on one study, which was made with endothelial cells. And it really depends on the tissue which you want to stimulate. And for the skin fibroblasts, we did see in literature that 2.5 times is absolutely enough. Yeah. So you could say 500,000, yeah, or you can say 2.5 times. But 500,000 is a value which is not always reachable, because when the patient has 150,000 platelets per microliter, it's different than when the patient has 300 or 400,000 or 200,000. That's why I prefer to say platelet concentration 2.5 times over baseline.
Okay, perfect. Where a lot of the other ones, you correct me if I'm wrong, is roughly around 1.6.
This is correct, yeah.
Okay, perfect. Next one. Some patients experience burning when injecting PRP. Is this the same with Arthrex PRF?
Pain? Well, there's
Or
always
burning sensation, should I
there's
say?
always some pain related due to the needle prick, but the burning sensation, you don't feel it because you have no anticoagulant.
Anticoagulant.
You feel that something gets injected, yeah, you can feel that it's turning a little bit warm, you can feel the prick of the needling, but I have treated some patients with non-anticoagulated and anticoagulated PRP, because with some patients it's so difficult to get blood. And after the first treatment, where I really had to do 2 or 3 attempts, I decided, okay, the next time I use an anticoagulant, because when it clots, then I really have a problem. And when you need to do a second, third, fourth attempt, then there is a certain likeliness that it could clot. Yeah? And they told me, it feels much more painful now. So for me, there's something behind that. Yeah.
Okay, perfect. What other benefits, again, I know you have said some in your presentation, but what are your main benefits when it comes to platelet-rich fibrin?
So the anticoagulated PRP, you have 2 options. Either you inject it like it is, and then a lot will be washed away from the bloodstream because it cannot form a clot there. No microclot formation is possible due to the anticoagulant. Or you activate it. If you activate it well, then the platelets open up immediately and release all the growth factors at the same time. The problem is you have just a specific amount of receptors in your skin, and the receptors will be full quite quickly. And the half-life time of these growth factors is quite short, and then they cannot work anymore. Whereas when you have the PRF, you have this desired clot, which releases the growth factors over many, many days or weeks. And therefore, the receptors can work again with the new growth factors over a longer period of time. And as I showed you, the migration assay and also the collagen formation in this paper was quite impressively better with the fluid PRF compared to PRP. I mean, 350% or 200% increase, that makes a big difference.
Big difference.
And also clinically, I mean, I'm using non-anticoagulated fluid PRF for many years now. I believe it's more powerful.
Perfect. I know we know the intervals between and how many treatments we would like a patient to do, but how long roughly, in your opinion, does it take for PRF to actually work?
Well, you have, let's say, especially when you combine it with needling, you have very quickly the glow. Yeah. But the mechanism of formation of new collagen fibers, this takes several weeks. Yeah.
Okay.
And there are some patients who are lucky and you see results just after a few weeks already. But for some, you need, or for most, you need multiple treatments, and the body needs time to build up new collagen fibers.
Okay. So Arthrex can also do microfat, like you explained, nanofat, and stromal vascular fraction, which is our SVF. Can you please explain more about the 3? Where would you place it, and how would you use it, and is it safe?
So first of all, terminology. When you reduce the particle size to 1.2 millimeter, 1,200 microns, that's the same, you speak about microfat. This has a solid structure and gives you volume. The adipocytes are intact. Microfat, or just normal fat, aspired fat, and after centrifugation, which is then emulsified by rapid passages through a small connector, is nanofat then. It's now an oily liquid substance. This nanofat was invented from Patrick Tonard several years ago. And this nanofat could be then, if you like it, filtered, pressed through a gauze or whatever. Or you use a second centrifugation run and get rid of the oil, because the oil could form oil cysts, and then you get out a pellet of SVF. So SVF is nanofat without oil. So you have a higher concentration, and you have not the risk of having oil cysts, which of course can be a benefit. A little bit of oil is okay, that makes it easier to inject. Filtering it has advantages and disadvantages. The advantage of non-filtering is you do not lose material. If you press this through a small, for example, 400 or 600 micron filter, then you are losing material. On the other hand, it allows you an injection with smaller diameters, with smaller needles and cannulas. From my perspective, the larger diameter 21 gauge is not really a disadvantage for facial treatments. It's a little bit more painful for the patient, but safety first. And with such a large cannula, it's extremely unlikely to inject it into a blood vessel. And we must ensure never ever injecting this product into blood vessels, obviously. So for me, I do not see the need for a filter, and the larger diameter is even better for safety when it comes to the selection of the cannulas. And the microfat, yes, this can be also easily injected with the 21 gauge cannula, blunt tipped. And from a safety aspect, again, here we must not inject it into any blood vessels.
Perfect. So we also know when it comes to SVF that, well, should I say fat in general, we have stem cells in our fats. So we do have a lot of it, but when it comes to SVF, we obviously want a more concentrated part of it. So when it comes to SVF, how much stem cells, I know patients are different, patient per patient, but roughly how much stem cells do you get in one offering if you get between 1 to 1.5
So
of SVF?
according to the data from the study from the Netherlands, which I presented to you, approximately 2.5 millions of total viable nucleated cells, a bit less than 50% true adipose-derived stem cells. So 1.2, 1.3 millions per milliliter. When you're getting 1.5 milliliters, approximately 2 millions, let's say it that way. Yeah.
No, that's perfect.
Could be also 3. It depends on the patient. Yeah.
Exactly. A lot of people also think the more, for example, when it comes to our ACP, right? We want between 1.5 mils. We don't want so much SVF in our tube still. So a lot of people always ask, isn't 1.5 mils of SVF too little? Don't you want 4-5 mils in the tube? But I believe I could be totally wrong, but I believe from my side, then it's not as concentrated than what you would like if you're trying to get a 1.5.
Of course, less volume means a higher concentration. So when you do the emulsification really well, you get frequently just 1 ml, but this is then much higher concentrated. And when you get 2 ml, it's okay. And when you get 3-4 ml, it means that the emulsification was not done 100% properly. It's still okay to use this, no doubt. Yeah, but at the end, the total number of stem cells will be very similar. Yeah, but it just means that the concentration is less. So everything between 1 and 3 or 4 ml is absolutely fine to be used when you get it.
Perfect. We're nearly there. A lot of patients seem to be contraindicated at the moment. So in the market, what our account managers are noticing is that due to COVID, due to the different amounts of flus and stuff that have been coming and going, that it has caused and brought up a lot of autoimmune diseases. So patients are ending up being contraindicated for HAs or biostimulators and things like this. Would this be the same with Arthrex?
Absolute contraindications for PRP and PRF are really rare. There are several studies that discuss that the efficacy could be reduced if the patient is suffering from autoimmune diseases. But there is no absolute contraindication. There is even some evidence that post-COVID hair loss can be treated with PRP, that also patients with Hashimoto thyroiditis, for example, showed beneficial outcomes. We do not have lots of cohorts with a suitable number of cases comparing them, but having a look and having reviewed hundreds of papers on PRP, I do not see absolute contraindications there. For me, an absolute contraindication is active cancer, especially active skin cancer. That's where I do not recommend doing a PRP treatment. When it's cured, it's fine, but as long as it's active, not. And apart from that, well, this is for your own safety, especially in your country. You need to decide how you handle the things with infectious diseases, especially HIV. I know that you are much more experienced with that than we are in our country, and have your protocols with on-site testing if required, if an accident with a needle injury happens. So you know how to handle this. I'm sure about that.
No, most definitely. Amazing. So I have two more questions for you. So a question in the market as well is going around. So at a certain age, and we will call it roughly 30, 40 years old, that we do not produce growth factors anymore. Is this correct?
Well, there will be growth factors everywhere. There is no cutoff regarding age. What we know is that, for example, stem cells are no more that active when you're getting older. And hypothetically, also the efficacy of PRP treatments could be less in older subjects. Still, in the studies, sometimes you see the best outcomes in old patients. There are so many factors that at the end influence the outcomes. And I do not see age as a very critical factor, as long as the patient is not extremely old. A patient who is 90 years old, I think that's not the right candidate for regenerative therapy, but up to 70 years, for me, this is perfectly fine.
Amazing.
When somebody with 77 or 80 wants to get this treatment, he or she still gets this treatment. I just inform the patient that there might be a reduced efficacy.
No, that sounds accurate. So our market is also, this is my last one, our market is also being told that exosomes are better than growth factors. I know you deal with exosomes overseas, and you deal with PRP and PRF. So what is your output on this?
So exosomes, that was the buzzword on the past conferences where I had been: IMCAS Paris, IMCAS Asia in Bangkok, Dubai Derma, everywhere, AMWC in Monte Carlo, everywhere exosomes are omnipresent. Exosomes are in all body's fluids. Exosomes are in blood as well. So in PRP there will be exosomes as well. Yeah. And exosomes are small. Also in the microfat, there will be exosomes in. Yeah. Adipose-derived stem cells secrete exosomes as well. Exosomes are responsible for communications between the cells. They are small packages filled with RNA, so with genetic information. And the entire mechanisms of all these biostimulator treatments, exosomes, PRP, PRF, not all mechanisms are understood. In my presentation, I informed you about the growth factors and the mechanisms that are postulated. For exosomes, not everything is understood at the moment. Research, of course, is conducted, but one of the big problems is the bottled exosomes, the off-the-shelf exosomes that you get. They are only cosmetic products. They are not approved for injection. Of course, there's a big hype now. Nobody or few people speak about adverse events. In Bangkok, in IMCAS Asia, I did see the first lecture last summer on complications with nodules, with long-lasting redness, long-lasting swellings, and so on and so on. So from my perspective, exosomes, yes, you can use them. I'm using, for example, platelet-derived exosomes, because when a patient asks me, do you have exosomes? I need to say yes, otherwise the patient is gone. But I do not like to use the off-the-shelf products at the moment, because I do not feel safe, as there are no safety studies for them. But with the platelet-derived exosomes, body's own product, I'm safe, and I fulfill the desire of the patient. And initial results indicate that the number of exosomes from blood with another system called ACP Max, I'm not sure if it is available in your country. In Europe, it was just launched, is even higher than in the off-the-shelf exosome products. So I found a solution for this.
Amazing. Fabulous. Well, thank you so much, Doctor. Let's have a look at some of the questions that we have here. Can one combine microfat, SVF, and exosome treatments in a single session?
You can, of course. I mean, microfat, as said, is a kind of bioactive filler, in fact, for volumization. SVF is for regeneration. It might be even more powerful than PRP, PRF. And exosomes, as I explained, exosomes are in PRF, exosomes are in PRP, exosomes are in the blood, exosomes are in adipose-derived stem cells and SVF. If you want to add them, feel free to do it. Yeah, but remain careful, especially when it comes to off-the-shelf products and where no safety data is available.
Perfect. Because she was looking at doing microfat and SVF for deep injection, exosomes for superficial, intradermal injection, and then PRF combined with exosomes specifically for intra-article injections.
Let's see what the best protocols will be. Of course, microfat should be placed in a subdermal plane, that's clear. SVF at the end, placing it really intradermally is not possible. It's on, let's say, at the junction, yeah. So as superficially as possible, but with a cannula, you're always somehow subdermal, yeah. And with exosomes, for example, platelet-derived exosomes, you can inject them intradermally. And what for the future, the outlook will be interesting is when we are getting huge volumes also of PPP, a combination of this, maybe to do it in both planes, subdermally and intradermally, to get the best effects. But the off-the-shelf products, they can be used only in a safe way for topical application at the moment.
Okay, thank you. Next one, when injecting microfat or SVF, what is the best option for anesthesia? Doing a local block or topical, and or mixing the local anesthetic into the fat?
Well, to be honest, it's not really painful for the patient. It's the same like, well, injecting a filler, you have lidocaine in the filler.
Yes.
But I was doing just amla cream with my patients and they were perfectly fine. You go in with the cannula in the subdermal tissue, the manipulation with the cannula is not really painful. The patients feel it. You could do a nerve block as well, absolutely, but I was using only amla cream and this was fine. And for the donor area, for harvesting the fat, you have your tumescent anesthesia. We are using the Klein's solution. So for 1 liter of saline, you add 1 milliliter, 1 to 1,000 adrenaline. You add 50 ml, 1% lidocaine, or 25 ml, 2% lidocaine, and you add bicarbonate 8.4%, 6 milliliters. That's the typical solution that we use. And of course, the patient feels it, but they tolerate it, let's say it that way.
Okay, perfect. Let's have a look here. Let's see. Is the treatment outcome with PRF directly proportionate when it comes to a patient's lifestyle, their diet, their lifestyle choices, things like that?
All these styles and habits will influence the outcome, but we do not exactly know how much. Smoking seems to be not desirable, obviously, yeah. And having a healthy diet will be desirable. Having a normal level of vitamin D is important, especially for all regenerative processes in the body. That's why, I mean, you have enough sunlight usually. That's an advantage. We in winter sometimes suggest that the patients take vitamin D orally to get a normal level before we do the treatments. But in your country, it shouldn't be a problem.
And then obviously a tip that I always saw from you was lots of water.
And for the diet, obviously, a good hydration is important always. And how, for example, insulin influences the quality of the PRP is not yet totally investigated. I believe that the insulin as an anabolic hormone will also play a role for the efficacy of the treatment, but there are hardly any studies on it. But this could all influence it.
Okay, perfect. Well, we're on to our last one, unless anyone else has any last questions. But does the microfat migrate?
Usually not. Usually you place it where you want to have it, and there it stays. If you inject it into the right plane, then it's like a filler. A good filler, if you place it into the right plane, it also remains where it is, and the same holds true for the microfat. What is important, that changes of the weight can have a big influence on the outcomes after fat grafting. So it's very important that the patient eats enough after the lipofilling, and even more than usually. And also movements are important, or having no movements. So I tell the patients, never ever wash your face with too much force, because this can destroy the microfat in the initial phase. This microfat needs to engraft, and there be as careful as possible. This is really important.
Okay, perfect. Well, thank you so much, Doctor. I don't see any more questions for today. I just want to thank you very, very much for taking the time out of your day to join us, as well as all the wonderful doctors and our clinics that are on the call with us now. If anyone wants any extra information, any extra clinical studies, please don't be scared to ask your area manager. They will sort you out very quickly. I also know Doctor was speaking about specific size cannulas in the beginning. We also have our cannula range, so please reach out as well to your account manager. They will send you all the information that you need. And that is it from me. Jax?
That's same. Thank you very much. Thoroughly enjoyed it, Dr. Hanno. I learned some more tips and tricks today, so absolutely amazing. Thank you for your time. Nice to see your face again. We need to do this more often, and I'm happy. Thank you very much for giving us your time and giving us your expertise and all your knowledge. And thank you for hosting for us today.
Thank you, everybody. Have a nice evening. Bye-bye.
Bye. Thank you.